My name is Dr. Ian Storch. I'm a board-certified gastroenterologist and osteopathic physician, and you are listening to DO or Do Not. If you are interested in joining our team or have suggestions or comments, please contact us at doordonotpodcast.com. Share our link with your friends and like us on Apple Podcasts, Facebook, Twitter, and Instagram. We hope you enjoy this episode.
Hello, my name is Brooke Pillegi, OMS 2 at the Alabama College of Osteopathic Medicine, and you are listening to DO or Do Not. In April of 2022, the American Association of Colleges of Osteopathic Medicine, otherwise known as AACOM, graciously invited the DO or Do Not podcast to attend their national meeting, Educating Leaders Conference in Denver, Colorado. Our two producers, myself, as well as Lerone Cark, who is an OMS 2 at the New York Institute of Technology College of Osteopathic Medicine, as well as Ben Berg, our premedical student liaison, attended the conference to continue our mission of promoting awareness of osteopathic medicine by interviewing leaders in the field. We would like to thank Dr. Robert Cain, president of AACOM, Joseph Shapiro, director of media relations, and Helene Cameron, vice president of medical education services, for having us at the conference and supporting the podcast. Personally, I had an amazing experience and would recommend the conference for any medical or pre-medical students interested in learning more about the inner workings of osteopathic medicine and osteopathic medical education. Today on the DO or Do Not podcast, we have Dr. Sharon Gustowski, the chair of the Department of Osteopathic Principles and Practices, or OPP, at Sam Houston State University College of Osteopathic Medicine. For those unfamiliar, DO's treatment modalities are similar to our MD counterparts, with OPP being one of the main factors that makes osteopathic physicians unique by giving us another tool in the tool belt with hands-on musculoskeletal treatment. In this episode, Dr. Gustowski discusses both her clinical practice, which focuses on manual therapy for children, as well as her role as a professor of OPP in Texas. She will further share her views on how new osteopathic students engage with the philosophies and techniques of osteopathic manipulative medicine, and why these techniques and philosophies bring value to all osteopathic students, regardless of what specialty they pursue. Welcome to the DO or Do Not podcast. Today we have Dr. Sharon Gustowski with us.
Thank you for inviting me.
Dr. Sharon Gustowski is the OPP Department Chair at Sam Houston State University College of Osteopathic Medicine. What a typical day or even a typical week looks like. Could you describe that for us?
The life of an academic physician is variable, and that's part of what I love. I'll have some days are full of meetings. A couple days a week I do teaching. 1/2 day a week I see patients. And then I've got the weekend to play catch up and get caught up on projects, a little rest, relaxation. Every day's a little bit different, and that's part of the appeal for me for being in academic medicine, is getting to do a lot of different things.
You mentioned that you have a 1/2 day a week that you see patients. Could you talk a little more on that? What type of patients do you see, and what type of OMM perhaps do you use?
I'm an NMM specialist, so I use OMM as the primary modality for treatment. Currently, I limit my practice to pediatrics. It's for a few reasons. One, just the physicality of doing OMM, and two, to meet the need of the pediatric patients. With a limited practice, if I opened it up to everybody, I might be overwhelmed and not be able to see very many patients. The techniques I use, like Dr. Still said, it's not about the technique, but I consider myself a cranial osteopath, and on children, a cranial approach is really helpful. But I'm very also biomechanical, right? Definitely find it, fix it, leave it alone, correct structural dysfunctions. Currently, I'm seeing a lot of patients with concussion, so post-concussion, as you know, OMT is a great treatment to include, but I'll see any child for anything and really enjoy working with that patient population.
How do you approach osteopathic techniques with a child? Are they pretty receptive to that, and their parents?
It is a little bit uniquely tailored to each patient. So when you have really young patients, newborns, I'd say up to about 2 or 3 months, there's a lot of explanation for the parents and a lot of parental involvement, right? Just letting somebody else touch your newborn can be scary. So a lot of parental involvement, a lot of allowing the parent to hold the child. That also really helps. An explanation of that the touch is gentle, I don't do popping or jerking techniques. A lot of reassurance for the patients. Reassurance also that I have experience working with children, like newborns with feeding dysfunction or plagiocephaly or torticollis. So a lot of reassurance, a lot of involvement of the parent in the activity, including the parent in keeping the child's attention. Like, oh, you can bring toys, you can play with them, allowing parents to nurse, feeding while getting treatment. Those things really help, allowing the child, as they get maybe older, to hold an electronic device, if that watching a video and listening to music. So just being really flexible and open. Sometimes I will touch the parent if they want to know what it feels like oh, it feels like this. And just a lot of trust building, so try to build that relationship. Explaining OMT is incredibly difficult, period. So I found that I'll try to just relate to the patient. So I can't give you one rote answer. I have many different answers. I also invite parents, when the children are younger and not verbal, to let me know if they feel that the child is uncomfortable. Sometimes babies cry, like if the cry is bothering you, do you want me to stop? So giving them permission to have some autonomy as they can. I explain that to older patients too. I can feel tightness in your tissues, but I can't feel if it hurts you. So let me know if anything I'm doing hurts.
What are some of your main responsibilities as the chair of the Department of Osteopathic Principles and Practice?
Right. A little bit of everything and other duties as assigned. And in a startup, maybe it's a little bit different from a school that's already ongoing, but as department chair, you manage faculty. We're still hiring, so managing the hiring, the search process. I'm also course director, so managing courses, representing the department in committee meetings, so a lot of service on committees. A little bit of putting out fires. You try to be preventive, right? Just like we do with our patients. So, ensuring that team and the department, that we're on the same page, that we have kind of policies and procedures that we know how to follow to prevent issues. I also spend time, especially as course director, talking with students when we need to, and not just at the bad times, but I have an open door policy, so students can stop in anytime to discuss whatever they'd like.
What factors played a role in your decision to enter academic medicine specifically?
I'm a little bit unique in having entered academic medicine right outside of residency. So in my residency at the Texas College of Osteopathic Medicine, part of the job was being in the classroom and doing the teaching. I found myself really interested in maybe not the actual delivery, but the design. Like, I really cared a lot about ensuring that what we taught and aligned with why we were teaching it and the students understood. Like, I wanted other students, other people to like what I liked, I guess. And way back when, 18 years ago, was kind of the start of the new schools. So new schools hadn't been opening up, but as they were opening, there was one opening in Las Vegas. The dean of students was the dean of students at AACOM. So I knew him, I knew he was opening a new school, and I said, do you have a job? I was also a little bit intimidated of going into a private practice by myself. So about 20 years ago, the OMM doctors in private practice basically had 1 or 2 rooms. They had one medical assistant. They were, and still are, largely fee-for-service, so not insurance-based. And the thought of opening up my own business and having what I thought might have been too much of an isolating experience for me personally, I was like, I don't know if I really want to do that. Academics afforded an employer, security, and a new opportunity. And I was comfortable already with the teaching environment, having done that at TCOM. So it was really a good fit, not just professionally of something I love and wanted to share, but also personally. And I think that's important. I think students are paying more attention to it now than maybe we were afforded. And I'm going to take this opportunity to ensure anyone who's interested in academics to not be afraid to go into it right after residency, despite differing opinions. Like, it's okay. If you feel it's your path, you can do it. A lot of words of wisdom that we hear say, go into academics later, get some clinical experience first, and then you can take that in. And if that's the right path for you, by all means do it, but don't feel obligated. If you really feel called to be in academics, to do some teaching, do some research that also interested me. I had an MPH. I'm like, how can I add to the body of literature? Everybody says we don't have literature. If you feel called to a specific path, listen to your inside. Don't let the external factors or what other people say be your only guiding influence. So don't be afraid to forge ahead in your way. I'm 18 years into an academic career, and I love it. I wouldn't have wanted to do it any other way.
When they're coming in as first years, what percentage do you think truly engage in those osteopathic techniques you're teaching them? And how does this compare to they move on to their second year, or when they leave the school and they're in their third and fourth or residency?
We hear this third percentage analogy kind of put out. Like, a third of the class isn't interested, a third of the class is, and a third of the class, I shouldn't say is undecided, and a third of the class is interested. I don't know that rings true anymore, and I really hate putting that perspective. So anyone out there want to do a survey, that's a great survey to try to find what the current status is. What I will say is, I'm not concerned with how the student got to the DO school, whether they chose it intentionally or it got chosen for them, what their opinions were before they came in, so much as I care about where they are now. And every student is invited to explore OMM. And I think that's the biggest thing I've learned from hearing the students and listening to maybe some naysayers or people who are concerned, is really worked very hard to allow the students to appreciate OMM from their perspective. So it's much less about being wrong or right, and I put in a lot of repetition and a lot of reassurance. If you don't get this now, it's okay. You have to get it enough. You've got boards to pass and you have a minimal competency to achieve, but we're going to do this again and again. And we're going to explore a lot of techniques, and you can ultimately pick which ones you really like. So I try to make an open environment. And I also think we're at a really great place where, our Generation Zs are coming up, and I know I'm making a generalization, but I'm seeing that uniqueness, individuality is supported and not discriminated, right? I grew up in an era where if you went to DO school, you got told, why don't you want to be a real doctor? Aren't you good enough? And I know some of that is out there, but I also know we're in an era that we are celebrating uniqueness and being different. And so I see my students taking that and saying, I have this unique skill. So I've just worked really hard to foster that attitude and that mentality, and I'm really encouraged. The last 5 years or so, been really encouraged that students embrace the unique distinction, osteopathic manipulation, and will try it out. And this might sound harsh, and I don't mean it harshly, but I don't tolerate speaking negatively about our profession, and the students know that, and there's no reason to. And it's okay to not like a part of your profession, but you don't have to be negative about it. And it's okay to not have a skill. We also say that too. I'm very honest. I'm not going to deliver a baby. It's not my skill. I'm not the best at suturing, right? I don't do it. If I had to in an emergency and needed to, I think I could call up my reserves and be safe and help the patient get through what they needed till we could get experts. And so that it's okay if they're not good at OMM. It doesn't mean it's a bad thing. Does that make sense? So we don't all have every skill set. So I've just worked really hard. I am more encouraged than ever that more students are embracing OMM and will do it. That's what I'm hearing from my students. A few weeks ago we had, I think, 30, maybe more students show up for the teaching assistant. We have an OMM teaching assistant program. Show up for the information session to learn more, to apply to become a TA. We only have about 12 spots. And this is a class of 112. So, I mean, it just really warms my heart that there's interest and enthusiasm. I think we're seeing the pendulum shift. I hope that's happening at other campuses. I believe it is, because I believe it's generational. I believe they're really embracing the uniqueness instead of feeling ashamed and that they're not as good as. So that's my hope. I'm encouraged. I try to keep OMM practical and allow students to explore it and use it as they think will fit their practice and their patient population.
Do you think that there's value to OPP to students even if they decide to go into specialty where maybe OMM is not too traditionally used or heavily used?
Absolutely, I do. Some of it, I have this view from what students have told me. My most favorite story is early on at my first institution, so kind of the first class I got to take through from first year to graduation, gets a pathology residency. And in pathology, right. OMM is not done, but she came back and she said one of the reasons she felt that she succeeded in matching into her preferred program was because she had palpatory skills. She could feel lymph nodes in the mesentery, and she was more accurate than her counterparts because of her palpatory skills. And so I tell this story year after year. The palpatory skills should not be underestimated, whether it's palpating a specimen, whether it's palpating your patient, right, abdomen, or beyond just musculoskeletal. So that's one skill that they can take. The other is any psychomotor skill. So anytime you're going to use your hands, so surgery, that can be even now like interventional radiology, right, PM&R. So a lot of doctor skills are hand skills, so try to emphasize the psychomotor. And the third thing I've seen the students take away from this is the conveyance of empathy through touch. So just being comfortable touching their patients is something that you develop because you start touching each other and you are touched. And so I include in a session touch and emotions, where we have students actually, with consent of a partner, have an emotion, touch their partner with it. And this is outside of class, so they can use a friend. And then we ask them to have maybe a negative emotion. Right, so like a positive and a negative emotion. Touch your partner, not tell them what it is, and then have your partner say how that touch felt. So they can start seeing that you can convey, emotions. Your empathy can come through with touch. So even that, at that basic level of comfort of touching somebody and knowing that your confidence, your empathy, your care is transmitted through your touch, even if it's a handshake or a tap on the shoulder, or you're touching their back while you're listening with your stethoscope. All of that gets conveyed. And so at the very least, you've done that. You've got a lot of options, so I think there are a lot of skills that you can take away from OMM, even if you don't use OMM in your practice.
So to shift gears here, can you tell us where you went to college and when you did decide to become a physician and kind of why you decided on osteopathic school?
Story for my book later.
Yeah.
Okay. You always plot and scheme for your future. So I wanted to become a doctor when I was 16. I read the book, The Road Less Traveled, and I wanted to help other people be happy in their lives, I suppose. I felt a strong call to service, and The Road Less Traveled was written by a psychologist, but my 16-year-old brain said, I like science, and I'm smart enough to be a doctor, so why not be a psychiatrist? And there it was, right? Sometimes when you're young and you just don't know, you make a choice and you can follow it. I ended up going to the University of Texas at Austin, and I got a degree in philosophy, because I would study science in medical school. I was absolutely certain at 16 I would become a physician, and there was really no doubt it. It was really, I guess, a naive conviction, right? Sometimes when you're younger, you don't know that things can't happen. And so I forged ahead again as a non-traditional student. And in my sophomore year, my mother started working for a DO who did manipulation, just by happenstance. Sent me the information. I'll never forget, it was on treating ear infections with OMT. I didn't know what a eustachian tube was, but they showed a picture, they talked about a technique, And I read a little bit of this article and some other information, and the little light went off or whatever it was, and I was like, that makes sense to me. That's what I want to do. I was very fortunate to have also received osteopathic manipulation before going to osteopathic medical school, so I got the experience of it. That being said, I never really thought I would use it until later in my career or in my medical education. I wasn't sure what kind of doctor I wanted to be exactly. And the thought of touching people for a living never really entered my mind early on. It took a while to put all of that together. And so obviously once I got to OMM class, it all just made sense to me. It turned out I could do it. I practiced on my friends. I went on to a traditional rotating internship, kind of not sure OMM versus family medicine. Things were different. There were a lot more rotating internships when I went through still. Things weren't linked as much. They were just starting to get. And halfway through my internship, I said, I am smart enough to be a doctor. Because that was the thing we get told. When you wanted to do an NMM residency, I still got the pushback, don't you want to be a real doctor? I still got that from teachers and mentors, and they meant well. I heard a lot of, you're never going to find a job as an OMM specialist. And that's the way it was, right? This is 20 years ago. Things were different. And I said, whatever. I went ahead and did it. And obviously, there are more jobs for OMM specialists than we have availability. But so I decided through my internship that I would choose NMM as a residency, and never looked back.
How did you balance everything, and what was your experience like?
Texas College of Osteopathic Medicine. I love it. I am a proud alumni. In fact, it's our 50th gala, like 50 years that the school has been around. So my medical experience was a little bit different. There were 4 or 6 of us that got recruited to also enroll in the Masters of Public Health program. We found ourselves taking a night class, summer school, to get biostats. It was, I like all-consuming because I've used the term emotionally, physically, spiritually, mentally taxing and draining. It was all of that, but I think at the time, when I look back at what I went through and my colleagues went through in medical school and what I see our students going through now, we were maybe a little ignorant. We didn't have terms like triggers or resilience or grit. You just did it, and maybe you didn't like it, but when somebody told you to take your shirt off for OMM, you had no choice but to do it. Well, now I don't tell people to take their shirts off, right? Because I didn't like it. We invite students to expose their skin as they're comfortable, right, for learning. And so you just kind of did it and commiserated and maybe didn't always do the best things for yourself. I'll say a lot of it was a blur. I didn't know that President Clinton was having an impeachment trial till well after the fact. So I think I just kind of kept my head down, put my blinders on, for better or worse. I don't recommend that to everybody. I think what I've taken away from my experience is I try to mentor students in identifying their values and priorities. And that was not something that was tended to. Our personal formation as people was not tended to. We were just achieve, get the score. And now we have the opportunity to do something different. So I will counsel students, do you have other goals and priorities outside of being a physician? Because if you do, it's okay to start thinking about them now. It's okay to make a B in your class if doing that means you're setting time aside to have a child or find a spouse or continue with another passion or hobby. Kind of give yourself permission if those are your goals. It's okay to not be 100%, but if you want to be number one, by all means, you do that, and whatever that takes, that's your goal. So I find that I try to help the students personalize their experience and be okay with their choices, because I feel like we didn't have that tending to. It just wasn't in the culture.
Right.
You just got up, you just did your job, and you just made it through. So somehow I made it through. I do see what I do as a vocation, and I think that does change your priorities and values. So that dribbles into my personal life where I am committed to my career, and that comes first most of the time.
What main factors played a role in you deciding on a specialty, and how did you ultimately choose? I know you had mentioned you were kind of between family med and that OMM kind of component. What was that deciding factor for you, if anything?
A couple of things. One was confidence in being a physician, that I could diagnose and treat at a basic level. That, I guess for me internally, like I knew that I was a real doctor. I guess I got that confidence. I had great teachers, especially my internship. We had some amazing preceptors, and it really bolstered my confidence in being able to manage whatever walked into my door. And so that confidence really, really helped. And I think the other thing was I did struggle waking up every day and going into a job where my primary method of treatment was pharmaceuticals or a procedure. And they have their place, but in my mind, I wanted to do something different for my patients. And I was good in OMM, and I enjoyed it. And it's that thing where I could do it every day, right? You wake up and you could do it every day, and it's fulfilling. And so I think that was those factors were kind of compelling, and I identified with people that also did OMM, right? So by going through to conferences like the American Academy of Osteopathy Convocation, I was around other like-minded people, and so that really helped also to see some examples of OMM only type people. So, and I really love it. It's a really intimate experience to watch somebody's body change under your hands. And so kind of once that solidified in me, then again, I made the decision OMM is going to be my primary treatment modality for patients, but using all the doctor skills that you learned for diagnosis and differentials and all that good stuff. So,
going to residency now, could you describe your experience as OMM resident? If you could even explain to our listeners maybe what that is. And
so it was primarily more of an academic. So we did more teaching than the current ACGME standards permit now. So we were teaching like 2 days a week. We saw patients and then did kind of rotations. I would say like the number one best thing was there was no call. It takes that load off, right? In part, there aren't OMM emergencies. If you have a pain emergency, you need something else to make that diagnosis and sort that out. So that was kind of a nice thing. And what it afforded me was the opportunity to do more reading and exploring. So I really immersed myself in reading different books that I had wanted to read, books, Roland Becker and Dr. Sutherland, reading more about biomechanics, the anatomy, and I spent my time in residency practicing, if that makes any sense. There was one time I had read do CV4s, this cranial technique. It's kind of esoteric in a way. And so I just did for a few weeks or a month. The patients came in, whatever they had, maybe I did a little something, but I did a CV4. I really utilized that opportunity to practice the techniques, knowing that my attending was also there as backup, and that can help. And just, like I said, still taking care of something if they had an ankle issue. But on almost every patient, I did a CV4 for a few months. So I wanted to see. And so I would encourage, especially in an NMM practice where you do have a lot more time with your patients, if there's something you wanted to try out, start practicing that. Use that, knowing you also should have an attending who could come through and help you if you can't get it, right? If man, that OA joint is still stuck. I can't figure that out. So it was a lot of self-directed learning, a lot of reading books of things I was interested in. And so I kind of did that instead of taking call. It's not a break. You still have to very much direct your learning, right? Use that time to read because you might not always have that. Or learn or take courses or whatever it is.
What is one attribute about yourself, you may even call it kind of your superpower, that you feel helped you to become successful as a physician?
I think I would have to say I am really resilient in ways that are too personal probably to describe for a podcast. So in my personal life and in my professional life, I feel I have resilience. I can forge through, and that even with patient care, right? I'm resilient. If a patient is resistant, maybe, I'm not going to give up, right? Like I'm going to keep going with them as long as they still want to keep going with me, right? Mm-hmm. In my professional life, sometimes you have some setbacks or you're going to have failures. That's normal, right? We hate that as doctors. Like failure is like a bad word. Mm-hmm. But failure is how you learn. Failure gives you an opportunity to grow, to see something from a new perspective. So even in some setbacks in my career, I pick myself up and forge ahead. Setbacks in my personal life, I pick myself up and forge ahead, right? I still have a tiny bit of hope I might fulfill some personal goals, so to not give up. So I think that has, whether I guess grit is the other side of resilience, right? That having that internal motivation to just keep forging ahead, I think is what has helped me, stay here and I think be successful. I feel I've achieved a lot of success in my career.
So our last question, this is one of my favorites, is can you share with us one piece of advice that you were given, maybe by a mentor, could be a family member, really anyone that you felt is most impactful that you'd like to pass on to other students listening?
I might offer you two.
Yeah.
The first is avoid excessive debt. Starting in college, avoid excessive debt, financial debt, because financial burdens wear on you, I think, in ways you might not realize until you get further down the line, right? So hearing friends who could, quote unquote, retire in their 40s versus colleagues who are working well into their 70s because they think they can't. So through your whole life, if you can avoid excessive debt, keep financial stability, it's a good thing. Don't neglect that part, right? We tend to, as doctors, not get trained in it. So find your financial stability. Avoiding debt is an easy way to do that. Maybe take that as a mantra. And the other is, as physicians, I don't know if this was explicitly said to me or just kind of in the cloud, like, you have doctor karma. That's what I call it. You will have it. The patients that need you, that you need, will come to you. If you get a slew of patients with low back pain, take note. Like, are you good at treating that? Or do you need some help treating that? You know what I mean? Like, accept your doctor karma and the patients that are coming to you. They're probably the patients that need you. Sometimes it can be difficult if you get, you're getting a lot of difficult patients. You're like, why me? Why is every patient taking like 20 minutes? I only have 15. Like, be okay with that. Be okay with your practice and kind of use that to get better at what you're doing, to take notice, to even incorporate it into your personal self. Because one patient, it's actually a patient's mother told me this, the doctor-patient relationship isn't just one way, it's two ways. What do you have to learn from the patient? It is a relationship. And, honoring that and using that to also help your personal growth, right? As you're better able to help other people. So kind of take that. And those messages came to me in like bits, but it was something I heard from a lot of doctors. Does that make sense? Like, yeah. You heard little bits of that. So I'd like to share that. Like, take your Dr. Karma and go with it. Thanks.
All right. Well, we really appreciate you coming on today and speaking with us.
Well, thank you. It's been super fun.
This concludes our episode of Do or Do Not. Send all inquiries, comments, suggestions, and even let us know if there's someone you want us to interview to doordonotpodcast@gmail.com. Don't forget to like us on Facebook at Do or Do Not Podcast for updates. If you enjoyed our podcast, please share it with your classmates and administration. We have plenty of more interviews lined up, and we're excited to share them with you. This is Tianyu Shea. Thank you guys so much for listening to Do or Do Not.